and I had this patient who just was, dealing with anxiety, and I tried them on several medications and nothing was helping. And I'd just seen them again, and I was just thinking, what can I do? What medication can I add? They've already been on these medications. And I felt like I was running out of options, and I was kind of stressing out. I was like, what do I do? I don't know what to do. And I was really anxious about my patient. And suddenly I thought, what? I'm anxious about my patient. Why is it okay for me to be anxious and it's not okay for them to be anxious?
Okay, so we'll just stare gleamingly into each other's eyes for about 20 seconds.
For how many seconds?
I think 20.
Can we do 30?
Doesn't work.
Without talking?
No. All right. Good morning, Dr. Burton. How are you?
Good.
Awesome. It's good to see you. Staying alive. I'm having a pretty good day. I'm really excited to kind of get into everything that we're going to talk about today. But as per the usual, I want to start with you. So who are you, and what is it that you do here at Redemption Psychiatry?
So I'm Dr. Burton, and I am a psychiatrist, general psychiatrist. I'm also the head of advanced procedures, specifically TMS and ketamine. But we also do a couple of others, VNS, which is vagal nerve stimulation, as well as deep brain stimulation. Dr. Friday heads that, but I'm involved in the other three.
Sweet. Very cool. So I want to get into all of those, especially vagal nerve, because I haven't really understood a lot about that yet.
Okay.
But let's start with what did you do before this, and how did you end up where you are now?
Okay. Well, I used to be a chemical engineer. So I got my degree in chemical engineering.
Right.
I liked chemistry, physics, and math. And I thought that this would be a degree that would fit all those. I had no idea what a chemical engineer was. Didn't realize that most chemical engineers work in oil plants, distilling crude oil. That's one of the biggest jobs of a chemical engineer. I ended up working at Thiokol, and they make solid rocket boosters. They produce the solid rocket boosters for the space shuttle. My project was actually the Minuteman missile. We did the first stage, and there are 3 propellants. So that was my big project. We were essentially re-outfitting Minuteman missiles.
Okay. So I'm going to derail and sidetrack here. It sounds like you're the person to ask.
Okay.
What's harder, psychiatry or rocket science?
Yeah, so that's an interesting question. They're very different.
How so?
One of the reasons that I decided not to stay in rocket science was I didn't have the daily contact with people. Now, I worked with people every day,
Right.
but I wasn't directly helping people. And so for me, that is my jam. That is my gig. I love understanding how people work. So I guess it depends on the person and how it fits them. I learned a lot of things in chemical engineering and rocket science about problem solving, things that I probably use every day, but it's more of the techniques, I guess, that I use every day. I don't use formulas for propellant or propulsion with what I do now.
Right. So when your kids bring you math homework, is it just the easiest thing ever, or do you still get confused?
It depends on how far they are in math. I don't remember everything from calculus.
Right.
So, but I can do kind of the beginning calculus. Yeah.
Okay. All right. So we'll kind of come back on track then. So from there, how did you end up at Redemption?
So I decided that I wanted to work more with people. I had been pre-med in undergraduate school, and so I continued that path. I went to University of Southern California for medical school. Was planning on being either a surgeon or an ophthalmologist. I did 2 years in eye research. Decided I didn't like eye research or ophthalmology.
Right.
And one of the pivotal moments was when I was in my 4th year. I was doing my rotation as the ophthalmology rotation, and we had a patient come in who had a eye injury, black eye, a young gal, and the resident started examining her. He was, clearing her for any structural damage, double vision, any orbital floor fractures, which, those bones are very fragile. So he's focused on all of this medical. And I was wondering, okay, how did she get a black eye?
Right.
And so I asked her, and she kind of reluctantly shared that her boyfriend had punched her. And I was going to, pursue it further. And then the resident was like, all right, well, you look good. You're good to go. And he sent her out. And he said, oh, by the way, that was good that you asked her about, some of that social history. And I thought, I really want to focus more on what's going on with people.
Right.
And so I didn't realize that I wanted psychiatry at the time, but it's funny, my family now says that I was always probing into people when I was younger. And they're like, you were a psychiatrist before you went to college. So, yeah.
Very interesting.
So that was a pivotal moment. I ended up choosing psychiatry, did my residency at Maricopa program here in the East Valley, in Phoenix, East Valley. And then I worked for a few years in an SMI clinic after I graduated from residency. SMI stands for severely mentally ill.
Right. How did that affect you?
It was a good experience. It really helped with my confidence in treating a broad range of illnesses. We had a high level of bipolar disorder and schizophrenia, as well as people with substance use issues, and a lot of social issues. It's really hard when this is really kind of the people that have such severe conditions that their ability to care for themselves, that housing is oftentimes a very big issue. So it was really instructive for me to work with these people and understand the dynamic of how their life affected the medications I was prescribing. And it was, I think I had more of a myopic view, a very narrow vision about what actually affects people. And so it was really helpful for me to get a broader view of how mental illness affects, how other things affect mental illness. And so at the time, I went to residency with Dr. Friday. I was a year ahead of him. And we were together. We were at the same time. I was chief resident. He was my, one of my vice chiefs. And so we worked together. We've known each other for a while. And then I actually graduated a year earlier than he did because he did a child fellowship. So I started work. He ended up, towards the end of his fellowship, starting Redemption Psychiatry, and started saying, hey, you want to come back, work with me? And so he was kind of chasing for me for a couple of years, but not really, because I actually really I've always wanted to work in the private setting. Right. So eventually, after 3 years at Centro Esperanza Clinic, I came to Redemption Psychiatry in 2015. So I've been here since. Yeah.
All right. So what's changed since 2015?
What has changed? Well,
what was that journey like? I guess that's really what I would like to know.
The journey starting in 2015.
Right.
One of the things that has kind of developed over time is an understanding of advanced treatments. In my residency, a lot of our training was really just around medication. TMS being a newer procedure, newer technology, even though it was really kind of developed in 1995, didn't become commercially available or covered by insurance until about 2013, only a couple of years before I started at Redemption. So it was kind of a new thing. We started to get involved in it right as I came on board at Redemption, and so I've been kind of with Dr. Friday in this journey of understanding what TMS is about. Initially it was just treating depression, and I shouldn't say just, because it's really such a powerful tool. When I was in residency, if people didn't respond to medications, it started to become how creative can you be with your prescription writing, which I still think is very valuable.
Right.
At the same time, there was certainly a point where I could clearly see people were not responding to medication, and any additional trial of a medication was only going to give them, maybe 5-10% more improvement in what, no matter how clever I was in my prescribing. One of the things that I've kind of learned over this, past 7 years, 8 years almost, is, how does TMS work? Transcranial magnetic stimulation. And Dr. Friday and I, again, I give a lot of kudos to him. It's been great working with him. He's a good friend, but he's also, just such a compassionate doctor. But yeah, in working with him, we've really gained an understanding that there are multiple theories of depression. The one theory that most people are familiar with is something we call the monoamine hypothesis. Monoamines are certain chemicals called serotonin, norepinephrine, dopamine. Those are things that people are aware of. And so when we give medications, the idea is that there's some kind of deficiency in the body's ability or the brain's ability to deliver the monoamines in a way that is effective and healthy for normal functioning. So it is something that actually works for a lot of people. The challenge comes in when medication doesn't work. And there are some other hypotheses or theories of depression that we don't talk about very much. One of those is called the glutamate hypothesis. There is only one medication, and it actually just came out just the end of 2022, that actually targets glutamate. It's actually not a monoamine, but it is actually a key neurotransmitter that is important in managing the body, health, mental health. So it's more complicated than that. But we only have one medication that targets glutamate. It's called Auvelity. I'm not putting out a plug for Auvelity, but I'm just saying.
Yeah.
So there's another hypothesis. It's called the cytotoxic theory of depression, and the idea behind this is that our bodies can undergo stress.
Right. It's
normal to undergo stress, and we have a inflammatory process that responds to that stress. So when we exercise, our body undergoes stress. And our body also has mechanisms to kind of restore. And people understand that when we exercise, we're actually breaking down the muscle to actually build it up. But the process by which we build it up is actually an inflammatory process. And so, inflammation actually gets a bad rap in our society nowadays. We view it as all bad. It's actually not all bad. The problem comes when there's too much of it.
Right. It's like acute versus chronic?
Perhaps. If you have too much inflammation or not enough time in between inflammatory episodes. So I suppose you could say acute would be exercising every couple of days, and then you give your body time to restore between workouts. Where chronic might be, I'm just going to work out 3 times a day, 7 days
every
a week
day till I drop.
Right. And you do that, and you're going to just start causing damage to your body, right? It's not going to make you stronger. So this is maybe the comparison with depression. There's a similar process that can go on with our brains. We're meant to be stressed. We're meant to be pushed. And we know that with exercise, even weightlifters will tell you the way you get stronger is you lift as many reps until you can't lift anymore, and then you do 2 more, right? But then you also give time in between your workouts to heal. We do this all the time, though, with our mental health, right? We push ourselves, especially, in the United States, our first world country, society, it's fast paced. We're expected to do superhuman things. So we, work for hours, 10 hours a day, come home, take care of the family, take kids to soccer and sports and music and whatever. And then we, cut on our sleep, 6 hours of sleep, and we go back to work. And then on the weekends, we really put it into gear and go to those, extra things. Right. It's like working out 3 times a day. And our brain doesn't have time to heal. So this inflammatory process breaks down the neurons, the connections that help to signal normally in the brain. So when this process happens, our brains stop working as effectively. People start to lose resilience. They don't have access to the coping mechanisms that they normally have. They know it, but for some reason they can't do it. I should be happy. I don't know why I'm not. I have all this good stuff in my life, and yet I'm not happy. So this is part of depression, right? It's the illogic. It doesn't make sense, and yet it does make sense because they've been pushed to the limit. It also makes sense that there's a different theory of depression. That those we call them dendrites, is one of the connectors between neurons, right? So there's actually evidence, and if you want to Google functional MRI depression, easy to see some of these studies that have demonstrated that there's lower functioning in the brain, especially some key parts of the brain, compared to people who are normal or not in a state of depression. So one of the things that is so really incredible about TMS is that it is a different type of treatment. It actually strengthens and helps to rejuvenate those connections, the dendrites. And it's, there's a parallel process too. The ketamine also can help with healing of the dendrites. It also targets glutamate. So, these 2 treatments together really can help with healing of the brain and the connections that help our brain to just process in a healthy way. So anyway, it's and one of the things that it makes sense to me that normally if you have dendrites that are working, you can still have dysfunction of the monoamines. So it doesn't necessarily mean that TMS and ketamine are always the treatment, and you can come off of medication. But it can make medication that people are on or have been on more effective. So sometimes our goal is to have people come off of medication, but a lot of times it's to get people healthier and, still with the medication that they're taking, medication that's effective for them. So anyway, it's a long answer, but ultimately it's having other tools to treat depression is really been amazing for me, because I feel like we're not so stuck when people are dealing with treatment-resistant depression. We have other tools that can help people.
Right. So with all those theories, is depression as we understand it, then more like a catch-all for a variety of different problems in the brain that just kind of have similar symptoms, or are they all interconnected?
It's a really good question. Part of I'll answer it in a little bit different way, but one of the tools that we use for diagnosing, it's called the Diagnostic and Statistical Manual for mental, the DSM. We're on the DSM-5 now. So there have actually been more than 5 versions because they occasionally will do a revision of one of the versions, right? One of the problems with even how our nomenclature, what we even call it. Depression, for instance, is 5. We have to meet 5 of 9 criteria to make a diagnosis of major depressive disorder. It's interesting, we call it major depressive disorder. Any other field of medicine, when you have a constellation of symptoms that you just have to meet a certain number of criteria, but not in any specific order, we call it a syndrome. So a syndrome is actually a lot more, gives more clarity to the diagnosis, right?
So what's the difference between a syndrome and a disorder? Because I understand, like, disorder generally means impacts your ability to live like a normal, healthy life.
Right, and that's what we mean when we say a mental health disorder, right? But there's also some misleading cues on that, because a disorder usually means it's one thing, right? So if someone has hypertension, that's a disorder of blood pressure. So how do you measure it? You just say your blood pressure is above a certain level. No matter who you are, what you are, if your blood pressure is above a certain level, there's one criteria. You have a hypertensive disorder. It's very straightforward. So if you take disorders like that, or even diabetes, it's a disorder of blood sugar. If you, in a certain time of fasting, have a certain level of blood sugar, you have diabetes. There's nothing fancy about it. It doesn't matter if you're male or female, or if you weigh a certain amount. The blood sugar is the only measure, right? So it's kind of this very simplistic disorder. So the problem comes in when we look at depression, kind of getting back to your question, we say, oh, you have depression? Oh, I knew someone who had depression. Yeah, you don't look like them. You must not have it.
Right.
Because we think it's one thing.
Right. And I think that's true with like a lot of disorders. ADHD, anxiety, they can have a variety of symptoms. And I think that's where that boxing comes in. Of it's like, well, you don't have these symptoms.
Right.
So you don't have it.
Exactly. We try to fit people into a box.
Right.
Of one thing. Oh, I knew someone who had borderline personality disorder, and I am not that person, so I must not have it.
Right.
And it's not really fair. I did a calculation one time, and you can do statistical. You look at the statistical probability, right? If you need 5, 6, 7, 8, or 9 criteria of any 9 criteria, and you look at all the possibilities for depression, actually it's the same for borderline personality disorder. You need 5 out of 9, at least 5 out of 9. I don't remember the exact number, but it's something on the order of, like, I think it was 243. There are 243 possibilities. If that is your criteria. You just need to have 5, 6, 7, 8, or 9 of 9 criteria. So in other words, just based on the criteria alone, and that's still oversimplifying it, there are 243 different types of depression.
Wow.
Depending on the combination that you put together, right? Again, that's oversimplifying it. 243 is oversimplifying it, right?
So what do you do with that as a practitioner?
Well, I think it's the important message, I think, is that understanding that everybody's unique. Everybody's different.
Right.
And so even when people have depression, it's really important to understand the person and what they're bringing to the table. I think it's also important for the person to be able to understand that they are unique and their depression or whatever, mental illness they deal with is unique. So I guess that's one of my goals is to inform patients that way. And sometimes I don't necessarily tell them that, but I feel like I can also tell them that by the way I treat them, by the way I act with them.
So going back to syndromes, what's the difference between, what is a syndrome?
Yeah, so a syndrome is essentially the way we diagnose in psychiatry. So in any other field of medicine, and I can't think of any specific syndrome in medicine, I should look one up, but it's essentially that, right? We have 20 criteria. Fibromyalgia might actually be a syndrome because there's certain pressure points that people need to meet, and so even fibromyalgia, but it's probably a little bit more simplistic. But syndromes are more certain criteria, and you just need to meet a certain number of them to meet this criteria. Yeah. As opposed to the kind of some of the more simplistic, like blood pressure, hypertension and high cholesterol, some of those disorders that we're very familiar with that are pretty straightforward.
Right.
Yeah.
So how does TMS treat depression?
So good question. And I somewhat answered some of that earlier, but kind of the idea is that we're trying to get the brain to function more effectively. We want to get those connections to signal more effectively. So it's, again, going back to the workout analogy, it's like the muscles have gotten weak. Our neurons are thinner. And we actually see that on studies where they actually look at the health of the neurons. They're thinner. They have less branches, the dendrites. So our goal in treating depression is to get, with TMS, is to get those connections thicker with more dendrites, more branches. We want to grow that tree so that it can more effectively signal throughout the brain. And the way we do it, TMS, transcranial magnetic stimulation, and this is where my engineering hat is helpful. It's really fascinating. It's this procedure where we use there are two types of TMS coils. One is called an H coil that's put up by one company, and every other TMS device on the market uses a figure 8 coil. But they all use the same principle, which is it comes from physics. Some people may not care about this, but it uses the right-hand rule, where every electrical field has a perpendicular magnetic field, and vice versa. So if we can create a magnetic field through this figure 8 coil, we also are creating this perpendicular electrical field. And so the way it works is you have two fields or two donuts that intersect with each other. And where they intersect, you get a doubling of the effect. So where that effect doubles, that is our treatment area, or the field that we create to treat people. So the reason this is all important is it creates a field that's about an inch from the coil. And that's important because we can place it on someone's head and directly stimulate the cortex of the brain without actually having to cut you open. We can actually stimulate people's brains directly. And we're actually not stimulating other structures as much. We do. There are some areas around the treatment that are affected as well. But it allows us to directly stimulate the brain. And so what does that do? Well, the process is we are stimulating the brain. When we stimulate a muscle, we cause it to contract. And when we cause it to contract, it starts to burn fuel. Whether you're doing it naturally by lifting weights and I'm saying I'm just going to move my arm, or if we use an electrical stimulus and we cause that muscle to contract, either way, the muscle's contracting, right? So it's the same thing with the brain. We're forcing that part of the brain, and there's a specific target called the dorsolateral prefrontal cortex. I keep pointing to it. It's about right here. But this is a target, and it's actually on the left side, is really the target where most of the dysfunction has been found in studies. It's not just that area, but where it connects to. But when we stimulate that area, we are causing those neurons to fire, which then draws glucose there. Well, if you want to get glucose to an area, you need to get blood flow to the area. So now we're actually stimulating blood flow to the area. The stimulation of blood flow to the area brings in nutrients. And so that helps to heal that brain tissue. It helps to make that brain tissue healthier. So when that brain tissue is healthier, it functions better. So that's kind of some of the meat, nuts and bolts of how TMS works.
Very interesting. I will say, now that I know you're an engineer, you make so much more sense to me.
How I think.
Yeah. Yeah. Well, my dad's an engineer, so
okay.
That's part of it, I think.
What kind?
He's civil, and my brother's mechanical.
I know I'm not civil.
It's okay.
I'm just kidding.
Anxiety. It has a high comorbidity with depression.
Yes.
How does that affect treatment in and outside of intensive treatment, right? So just with normal medications as well as with TMS and ketamine. What is anxiety, and how do they work together?
Yeah, so I'm really tempted to be a little bit irreverent here. It's one of probably our least favorite things to treat.
Why is that?
Because it's so difficult to treat. It's so difficult.
Right.
And, so many people have anxiety. And I think that's one of the challenges is that it's so hard to treat, and yet we know how much it affects people. I had this experience in residency, and it taught me something very important about anxiety. So it was my third year, but my first year doing outpatient clinic, and I had this patient who just was, dealing with anxiety, and I tried them on several medications, and nothing was helping. And I'd just seen them again, and I was just thinking, what can I do? What medication can I add? They've already been on these medications. And I felt like I was running out of options, and I was kind of stressing out. I was like, what do I do? I don't know what to do. And I was really anxious about my patient. And suddenly I thought, what? I'm anxious about my patient. Why is it okay for me to be anxious, and it's not okay for them to be anxious? And suddenly I had this epiphany. I thought, oh my gosh, anxiety is part of life, right? So that started to shift how I approached anxiety. And part of the shift is the expectations. I think some people come in with this expectation that we shouldn't have anxiety.
Right.
And yet, many people know that anxiety is really healthy. Anxiety is something that helps.
Keeps you
it
alive.
Motivates us.
Yeah.
It what?
Keeps you alive.
It keeps you alive. Right. And so it can be very protective. I sometimes will use the analogy, if someone sees a child playing in the street and they see a car coming, I sure hope you have anxiety.
Right.
Because anxiety is going to motivate you to do something, to yell to the kid, to run out, to grab them, to yell to the car, to do something. If you didn't have anxiety, you'd be like, yeah, I guess
What
they're in the
happens,
street.
happens.
I don't know. I guess that car's coming.
Yeah.
Right? You wouldn't do anything.
Right.
So anxiety can be really healthy. It can be really good. And so that's one of the challenges, I think, in treating anxiety is it's not getting rid of anxiety. And I think that is the challenge. It's teaching people that they need to change their relationship with anxiety. It's kind of similar to eating disorders. Eating disorders, you can't say, it's not like alcohol where you can just live with alcohol. No more alcohol. Okay. You can live life without alcohol.
No more eating.
No more eating. No, you're going to die.
Yeah.
You have to change your relationship with eating.
Mm-hmm.
And we have to change our relationship with anxiety. But that's not easy to do, right? It's like, okay, well, how though? Like, how do I change my eating habits? I really like donuts.
Mm-hmm.
Okay,
So
well, maybe you have less donuts.
is that where counseling and sort of the non-medication side of mental health treatment comes in?
Yes.
Okay.
Yeah, that's a big part of it. Mm-hmm. And it's something I try to incorporate in what I do, but absolutely. And it depends on the level that people deal with. It depends on the level of anxiety and the level of their, expectations, I should say, and maybe distorted expectations of what anxiety should look like. Sometimes it can get so interwoven where healthy anxiety becomes really unhealthy anxiety. And sometimes it takes, a really skilled therapist to help people unravel those two. Because, a lot of times when I share this analogy, people will say, well, but too much anxiety is bad. Absolutely.
Right.
Very much agree with that. And the tricky part is unraveling that, right? How do you unravel what part is healthy and what is not?
Right.
Go ahead.
No, you're okay. I was going to say it's like stage fright. You should have enough anxiety to not say something dumb in front of 100 people. But when you can't get on stage, it's too much. Right? Or when you get on stage and you can't stop your body from shaking. It's too much.
Yes. And yet at the same time, this is part of the intricacies of it, right? How many people do you know, and I know you've been involved a little bit in performance and music, right? How many performers do you know that get on stage and never come off the stage without sweaty armpits?
Yeah, very few.
Like, I don't know if that happens.
Right.
And what is that? What is sweaty armpits? It's an adrenaline response, right? It increases heart rate. It increases breathing.
And that's part of what's so addicting about it.
So, yeah, it can be. Yeah, it's funny you say that. I had a patient one time who she was really frustrated with her husband because she had panic. She had panic disorder. And her husband one day said, I don't get it. Like, you have this, like, high heart rate and sweating and you're elevated.
Shouldn't you feel great?
People pay money to get that feeling. They do bungee jumping and things like that. They do these extreme sports.
And you're just getting it for free.
Yeah, she's getting it for free. And she said, well, the difference is I don't want to have it, right? Which, there's some truth to that, right? So that's part of the difference there. Again, it's expectations though, right? I think the person who expects to get on stage and not sweat and not have an increased heart rate, they're going to be disappointed because that's part of, if you're going to be up in front of 100 or 1,000 people, whatever, even 10 people, you're going to have that adrenaline response. That's normal. And it's actually really healthy, but it's understanding that you want to work with it. I once heard another psychiatrist say that anxiety is like our shadow. And when people have an unhealthy relationship with anxiety, they try to hide from their shadow. And so, they try to stay in dark places, right? They don't want to go out in the sun, proverbially, but sometimes literally, right? But it's understanding that your shadow is going to be with you all the time. It's always going to be there. Now, you don't see it very well at night when you only have a nightlight. It's still there. But it's going to be very noticeable when you're out in the bright sun. And, I think that is kind of like anxiety, right? It waxes and wanes, but it's always there.
Right.
It's never going to go away. So it's really important to find ways to manage it. Now, of course, there are also it's other things that can contribute to it, right? Depression, other comorbidities, untreated ADHD. Sometimes people have medical conditions like a hyperthyroid state can activate the response all the time, right? Activate that adrenaline response all the time. And so when people have that activation all the time, it wears on you, and that's actually not good and healthy. So it is, it's always this balance. It's always a balance. But you can see why it's not the easiest, right? Depression, in many ways, is actually easier to treat than anxiety.
All right. We're running out of time.
Okay.
If you could tell patients who struggle with depression and anxiety, specifically patients who are wondering, might be at the beginning of a journey, right, as to what to do, what's the correct decision to make. If you could tell them one thing, what would you tell them?
Well, I might tell this story. When we are in school, and maybe this is not the best story because not everybody likes math, but
I hate math.
Oh, you do?
Yeah, that's why I didn't follow in the engineer footsteps. That's why I came into mental health.
Gotcha.
Yeah.
So, well, you'll tell me then if this is a good analogy. But when we go to school and we have a math teacher, we expect our teacher to give us problems to solve, right? We need to have math problems and do it over and over to learn how to solve them. And if we had a math teacher that showed us a problem one time and then said, okay, you got it now, we'd say they're a bad teacher.
Right.
They're not really helping us. But it's interesting. So in that setting, we expect problems. Because we understand that it helps us to learn. And the more we do them, the more effective we become at them. But with life, when we have problems, a lot of times we immediately say, what's wrong with me? Why do I have bad luck? Oh my gosh, why is this happening to me? Or why do I do this to myself? It's all these like negative judgments about ourselves. I know this sounds a little bit Pollyanna, but I think the principle is still there. Problems help us learn. And even really difficult problems, really undesirable problems, things that are hard, like dealing with death or dealing with divorce or dealing with a family member with substance use, or, those really horrible ones that we really don't wish on anybody. And yet I will tell you that being able to learn something from those problems is something that can really strengthen us. I'm not saying it's easy, and I'm not saying it's desirable. And I'm not saying that there's, necessarily some like, oh, no, this is good for you. Because, sometimes math problems doesn't feel good for us, right?
Yeah,
right?
Amen.
At the same time, I think if we can look for the learning in it, that can help us in our journey. And I know it's a lot more complicated than that, and I really don't want to minimize the challenges that people have. Sometimes, if people want to extend this analogy out, yes. Sometimes you have a bad teacher. Sometimes you don't have a tutor to help you with those hard problems. And I'm sure the analogies could go on as to why getting all those math problems is not a good thing. But I still stand by that principle that, I think there's hope. I have seen people with extremely difficult circumstances make improvements, find peace. Find more peace in their life, find ability to manage their challenges in a way that they feel more empowered.
Well, Dr. Burton, thanks so much for coming on.
All right, thanks so much.
Awesome. Yep.
Sweet. No, we don't stare at each other for 20 seconds at the end.
We can if you want.
I was looking forward to that.